Hello everyone, Assalamu alaikum wa rahmatullahi wa barakatuh. Today my topic about transient ischemic attack. How can investigate the patient present to emergency department with transient ischemic symptoms and how can manage him. You know that NICE guidelines changed in 2019, and this is very important to know these changes because this is what will be asked in the exam. So for who will take MRCP examination, either part 1 or part 2 written exam, or also for who will take basis exam. It is very important to know these changes. Also in our life, it's very important to know what changed in these guidelines to know how can dealing with the patient with the symptoms of transient ischemic attack. All of us know what the definition of transient ischemic attack. So the old definition, as you remember, is a clinical syndrome characterized by the sudden onset of focal neurological symptoms that resolve within 24 hours. And usually, as we know, that usually the symptoms will last less than 1 hour. So this is the old definition. So old definition of TIA is reversible focal neurological deficit, affect the retina, the brain, the spinal cord, but the symptoms usually last less than 24 hours and usually ideally less than 1 hour. This is the old one. What is changed in this old definition? This change what's written here and nowadays, and no infarction is visualized on the brain imaging. Why this is changed? Because they found that up to 50% of people present with symptoms of transient ischemic attack, they have ischemic changes when we do brain MRI with diffusion time. So now the new definition of the TIA is a clinical syndrome characterized by a sudden onset of focal neurological symptoms that can affect the retina or brain or spinal cord. The symptoms resolve within 24 hours, also typically lasting minutes only, and this is very important, and no infarction is visualized on the brain imaging. So this is the first idea. So now, first of all, what you should do, and this is examic questions, either in PACES or in written exam. What you should do for patient present to emergency department with symptoms consistent with TIA. I should do CT brain or no? This is the first questions, and this is the important questions now. So according to these NICE guidelines, don't offer CT brain for people with suspected TIA unless there is clinical suspicion of alternative diagnosis that CT should be detected. So no need to do CT brain for patient has symptoms resolve within 24 hours, suspected TIA. This is the first of all. So when I should do CT? Yes, when I suspect something else, like patient has headache, patient on anticoagulation, patient has head injury, the patient has repetitive stereotyped events such as epilepsy, the patient has decreased level of consciousness or loss of consciousness. In these situations, yes, I should do CT. But if the patient present to emergency department, told you that I have heaviness of tongue, limb weakness, symptoms of amyloidosis fugax, that transient loss of vision, and the patient improve, so here no need to do CT brain. What I should do? I should refer the patient to be seen by neurologist or stroke specialist, but should be within 24 hours. As you remember before, we were using before APCD score to evaluate the patient whether should be seen immediately or can be referred to outpatient clinic within 2 weeks. This is now changed. All patient present with symptoms of TIA should be seen by stroke specialist or neurologist within 24 hours for evaluation and to do brain MRI with diffusion time. So this is the first important thing. Now, so first step, for all patients to present to emergency department or to clinic with symptoms of TIA, I should do brain MRI with diffusion weighted time and blood sensitive sequences. This is the question. So if you see the questions in the exam, the best choice, I should do brain MRI with diffusion weight and blood sensitive sequences to determine whether this patient has ischemic change. So this means that this patient has ischemic stroke, or the patient has no changes on MRI. So this means that this patient has TIA. Then, next step after brain MRI, and this is the important step, that I should carotid imaging. This is very important. Everyone with TIA who after specialist assessment is considered as a candidate for carotid artectomy should be urgent carotid imaging. So this is a very important issue. Now, what I give the patient? I will offer the patient aspirin 300 milligram daily unless contraindicated. So any patient I suspect I have that has TIA, I should offer for him now first step 300 milligram immediately. We know that the benefit of aspirin, if given within 48 hours after symptoms of TIA or ischemic stroke, this can decrease the risk of a stroke or recurrent stroke in secondary care. This is very important. So next step, I should give the patient, all patients suspected with TIA, I should give them aspirin 300 milligram daily. This can decrease the possibility of risk. And if we balance the benefit-risk ratio of aspirin, we'll find that the benefit from aspirin to prevent other attacks is really overweight the risk of complication of aspirin like allergy or gastrointestinal bleeding. So, important point here, and this very important point, especially for who will take PACES exam, don't use a scoring system. Don't use a scoring system. This is very important, like APCD2 score. Don't use it. So please, if the examiner asks you what you will do for patient, don't tell him I will do ABCD score to know if I need to admit patient in hospital or to refer him to clinic. No, all patients with TIA should be evaluated either inpatient or outpatient, but within 24 hours by a neurologist or a stroke specialist. Now, for carotid artectomy. For carotid artectomy, really this is a very important issue. Carotid artectomy should be done as soon as possible, early, urgently, if the patient has, if a patient indicated for carotid artectomy. Don't delay the patient. Don't delay this, because we know that the risk of a stroke in patients with severe carotid stenosis is very high. So the guidelines mention that if the patient has stenosis, symptomatic, this is very important, symptomatic carotid stenosis, the patient has non-disabling stroke, this is very important, non-disabling stroke. This means that if the patient has complete or dense hemiplegia, so this is not indicated for now for artectomy. So people with stable neurological symptoms from acute non-disabling stroke or TIA who has symptomatic carotid stenosis of 50 to 99 according to North American symptomatic carotid artectomy trials. This should be mentioned because this is what mentioned in the guidelines. So in the exam, if the examiner asks you what are indications for urgent carotid artectomy, you should mention that patient with stable neurological symptoms from acute non-disabling stroke or TIA who have symptomatic carotid stenosis of 50 to 99% according to North American symptomatic carotid artectomy criteria. So this patient should be referred for carotid artectomy. If the patient has stenosis less than 50% according to North American symptomatic carotid artectomy or less than 70 according to European carotid surgery trial. So this patient no need surgery, only should be given medical treatment like controlled blood pressure, antiplatelet agent, cholesterol lowering through diet and drugs, and lifestyle advice. So this is according to carotid artectomy. So what are the changes in the new guidelines? What it changes? It changes that, first of all, don't offer CT scanning to people with suspected TIA unless there is a clinical suspicion of an alternative diagnosis that CT could detect it. Second one, refer immediately people who have had suspected TIA for specialist assessment and investigation to be seen within 24 hours of onset of symptoms, and these patients should be evaluated by brain MRI with diffusion time. Last point, don't use a scoring system such as ABCD to assess the risk of subsequent stroke or to inform urgency of referral for people who have had suspected or confirmed TIA. This is everything for today. I hope that will be very beneficial lectures, and you can depend on these lectures for written exam or for PACES exam. Thank you very much. See you later.